all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. You must have seen Dr. Bill Murphy on my show before as well. Whenever he is with us, he increases the ambience of our channel. Today we are live on 5 channels with him. Dr. Murphy, welcome.
Thank you very much. Pleasure to be here.
Thank you. So very quickly, let me introduce Dr. Murphy, and then um, we would start asking some questions about cancer biology, cancer immunology, what are cancers, what are tumors, and so on. So here, this is UC Davis Health Department of Dermatology. Dr. Bill Murphy is Distinguished Professor, Vice Chair of Research, Department of Dermatology, Distinguished Professor, Department of Internal Medicine, Division of Hematology Oncology, and his research interest is cancer immunotherapy and graft versus host disease. And just some highlights from his biography. Dr. Murphy spent his postdoctoral years and early career at the National Cancer Institute in Frederick, Maryland. In 2008, Dr. Murphy moved his lab to University of California, Davis School of Medicine. In 2018, he became distinguished professor at UC Davis. Dr. Murphy's lab studies various aspects within cancer immunology and immunotherapy, including publications in cancer immunology, immunotherapy over his 30 years career. So now actually 35 years. So Dr. Murphy, you were talking about your work for 35 years and nowadays CAR T. So before we go to cancers, how is the research in CAR T? What is the promise of this research?
So, yeah, CAR T cells, which are basically a genetic engineered T cells, are the next wave of some cancer treatments. Right now, they're FDA approved for leukemia and lymphoma, mainly B cell leukemia and lymphoma. And they, I wouldn't be surprised if that becomes a Nobel Prize in the next, say, several years, because it's a game changer. It used to be if you had a B cell lymphoma, leukemia, and you've relapsed, you'd have to get a bone marrow transplant, which is very difficult. And even then, there was still a high relapse rate. With these CAR T cells, now we're dealing with the first generation CARs didn't work. Now we're dealing with fourth, fifth generation, and we're seeing cures, long-term cures. And so now they're being increasingly applied as a frontline therapy for B cell leukemia lymphoma. The promise of CARs is to say, can we, the big issue is solid tumors. That's been where the holy grail of cancer. When you think about cancer, most tumors, most cancers that affect people are solid tumors. I mean, solid tissues, breast, colon, prostate, liver, things like that. And that's been, it's been much more difficult to apply this kind of therapy, but that's where the next wave is going. So it's very exciting, but CAR therapy is very expensive. One CAR treatment costs $500,000, just the treatment. It can
Wow.
cost $1 million when you deal with the hospital stay and everything else. So it's literally, you're swinging for the fence, but it can really, with relapse patients, it can work and has a very high cure rate. So that's where there's a lot of excitement, and we're doing trials here at UC Davis. It's becoming now more and more. Now the big push with CAR therapy is, how do we make it more affordable? How do we make it more accessible? And so that's where you're seeing more and more a push, not just in the United States, but worldwide. There's a big, because it's the fiscal toxicity of cancer treatment that is really a major issue in our country and worldwide. And that's unfortunately, when you're dealing with personalized medicine, that means they're taking your cells out, genetically modifying them, which is a lot harder than it sounds, putting them back in. There's a lot of things that have to be done to get that to work. And that's where we're working on it, as far as ways to make this more efficient.
Understood. Thank you so much for working on that. And we would do a deeper dive in CAR T cell technologies as well. So let's now set up for this series of talks on cancer. Let's set up some foundational concepts. So what are cancers, or what is cancer, what is basic tumor biology, what are any misconceptions? Can you tell us a little about that?
Yeah, it's interesting because I teach graduate level cancer immunology, and I've been doing it for many years. And one thing that always amazed me was people have a gestalt on what cancer is. But if you actually ask anybody, even people working on cancer, well, what is cancer? And it's amazing to me on how you'll get different ideas and misconceptions. Misconceptions can range a whole gamut of cancer's one disease, cancer's contagious, cancer's inherited. You can give cancer to somebody. I've had actually people on the street say when they found out I do cancer research, oh, I hear cancer's been cured, but pharmaceutical companies don't want to release the cure, kind of a thing. So you get a whole gamut. And then also, basically, as far as the what causes cancer, and so I think there's been a lot of misconceptions. The internet's both good and bad as far as that goes. But even when my graduate class, I have to first lay the ground rules. What is cancer? What do we define as something as being malignant? So you'll hear words malignancy, you'll hear tumor, you'll hear cancer, you'll hear neoplasm, and they're not all synonymous. Then, right? So you can have a tumor as any swelling. I mean, you can hit your arm and it swells. Technically, that's a tumor, right? But it's the kind of thing where when it becomes to be a cancer, you're dealing with something that what we call malignant. That means it has to have certain key components. One, this is a genetic alteration. There are mutations that occur that are irreversible that cause that cell now to become what we call autonomous, which means it starts to grow on its own. But that doesn't make it cancer, right? To truly become malignant, when you hear that word, that means it has to have a property, what we call invasiveness. That means it spreads and then usually metastasizes. That means it goes distal. And usually for solid tumors and many cancers, it's the metastasis, the spreading, that will actually cause death. Now, that's not to say that if it doesn't spread, there are certain like brain tumors and other tumors, if it's in a vital organ, it doesn't necessarily have to be malignant per se, but it can keep growing. But that at least it's contained. And so the major issue with cancer that most people have a hard time with is that it will go in other areas and it will be gone on its own. Another misconception about cancer is that it always grows fast. And that is unfortunate because while many cancers do grow very fast, and that's how many kinds of therapies like chemotherapy and radiation therapy work, is on the idea that it's killing cells that are growing faster than the normal cells. Some cancers grow very slow. And in fact, some cancers you don't even treat because they grow so slow that the treatments may be more toxic than the cancer itself. And that's another misconception. And then
Got
also,
it.
how we treat cancers is going to be very different based on the types of cancers. And many people feel that, when they hear breast cancer or they hear colon cancer, they're not realizing there are many, many different types, subtypes can be very different. And in fact, there could be thousands of different cancers, and that we're trying to understand now, where people will sometimes lump them as to one basically cancer type. Does that make sense?
It does make sense. Thank you very much for this. So, uh, cancers, tumors, metastases, conceptions, misconceptions, uh, causes of cancer, and demographics. I was reading, and I actually presented a study as well, that cancers are on the rise, especially in the younger adults. So, what are the causes of cancers and how the demographics are changing?
Yeah, that's a fascinating area because, before the advent of antibiotics, right, the average lifespan of human beings was usually in the 40s and 50s. But the average time of cancer diagnosis is usually over the age of 55. And most people don't realize that cancer, as an evolutionary pressure, it really hasn't existed. right? And so cancer is considered more of a disease of aging because cancer can have many causes, but usually as fundamental, there are it's a DNA changes, mutations that occur, and these can occur over time and accumulate. So another misconception about cancer is that when somebody says, "Oh, I have breast cancer or lung cancer," oh, if only I last year, had stopped something, it wouldn't have happened. Some cancers can occur over a period of 20 to 30 years of constant changes and insults. So, what causes cancer is multifactorial, but ultimately, these are genetic changes, and these can result from primarily two different components. One, there is a genetic, for some cancers, propensity. That means there are some cancers that you can be susceptible to based on some of your genes that may be involved in DNA repair, like BRCA1, BRCA2 for breast cancer and ovarian cancer. So there's clearly a genetic component that may make you more susceptible. That's one thing. Cancers of children are very rare. When you look at the cancer incidence, while we hear about it, and it is obviously very traumatic, but they count for an extremely small percentage of cancers, and usually those are a result of a real genetic defect that has occurred that can cause that to occur very rapidly. With adult cancers, you're dealing with usually successive genetic alterations from carcinogens that accumulate. And so, what you're seeing is that with cancers, our society changes, our demographics change. We're living longer, we're living older. As I mentioned, obesity it's at a huge, it's at pandemic levels. It's 40 or 50% of the U.S. population will be considered obese. And obesity fuels cancer because anything that causes a nutrient rich environment, the tumor is going to take advantage of. So, obesity not only causes an increase in incidence of cancer, it also causes increase in progression of cancer and also causes decreased outcome because of cancer and mortality. It's one of the things that has definitely. So, our society changing, all right, has also affected cancer incidence. So, for example, lung cancer. I remember reading there was a pathology text, a medical school pathology text from the late 1800s that said you will never see lung cancer in your lifetime, where you almost are ashamed to show it in a pathology textbook. And then smoking came, and then all of a sudden, smoking-induced cancers went, and lung cancer went through the roof. Now with smoking going down, when at the time when lung cancer and smoking-induced cancers were high, non-smoking lung cancer was actually rare, and now we're seeing that going up. And so you're clearly seeing what our society is doing as far as what we're being exposed to and how we're actually living is changing the cancers we're getting. And so now we're seeing, like you mentioned, there's been increased incidence of gastrointestinal cancers in younger people, unexplained. So one has to think diet, and it's not just obesity. So now we're realizing obesity was an oversimplification. It's also muscle mass, sarcopenia is actually, so you can be a normal BMI, but it's also the muscle you have. And so, and then the diet. So those are all things that contribute. And so I think that's why you're seeing what we see as cancer now may be different, say, 40 years from now, on what we see as cancer. All right, because of our population changes. And I think aging is a big one.
That's very interesting. So, hypothetical, as we are now living longer,
Hmm.
there are more cancers as well. We have also taken care of many of the infectious diseases too, although not SARS-CoV-2 was not a great example.
Hmm.
Do you think that as we are also now doing the aging sciences or anti-aging sciences, will that, and I'm asking you something to predict, which of course it's just going to be a prediction, would that actually cause even more cancers by adding some more interference with the cells, or that would actually keep a person younger and so lesser cancers? Any comment?
It's an interesting question because we're pushing the boundaries as a species. We've never lived this long, right? And we've never lived this affluent for the most part. Where nutrition now, how much, like for example, whether it's meat-based diet or whatever, and then also being indoors. Before, we were more of an outdoors. Now we're monitoring vitamin D levels, right? Because that used to be not really thought about as an issue, but now being COVID certainly didn't help. Being indoors, just being outside, vitamin D affects your immune system. The other issue is clearly as a species, it's been, obviously as a man, that we would monitor PSA levels for prostate. But above a certain age, 65, it's not worth it because it's thought that men die of old age before, otherwise we'd all die of prostate cancer because every male's prostate starts to get dysfunctional.
Yeah.
And so the thing is, I think that may depend on the organs that we're looking at and what's geared for being able to be sort of reprogrammed. There's this concept of senescence, right? That as you age, your cells start crapping out, and these senescent cells cause damage. It's thought even with Alzheimer's in the brain. So believe it or not, people are looking at maybe can we target the senescent cells with the immune system, and maybe we can take care of some of the aging effects or the toxicities with aging. Because another thing to keep in mind, if you have breast cancer, how you treat the same breast cancer is going to be very different if you're 30, 55, and 75, right? Because how you're going to handle the treatments, and then also what kind of other kinds of collateral damage you're going to have, are all going to. So a 75-year-old individual with breast cancer may not get chemotherapy because of the toxicities, and the hormone levels are going to be. It's very different environment versus a 30-year-old versus even a child. So that's the other thing is, unfortunately, people need to realize cancer, as with everything else, whether it's vaccines, as far as your immune system, it's very different depending on your age and your situation. And then how you would treat is going to be very different on your age and then what you can handle.
Got it. Thank you very much. I have one more question before we go to the invasions and metastasis. The For last 20 years, cancers are increasing in youngsters.
Mhm.
Is the outcome of the cancer better in youngsters, or the outcomes are similar as older age?
Usually, it's been found that the younger you are, the better the outcomes for several reasons. One, even the cornerstones of most cancer treatments are still the same, which is usually cytoreductive therapy, which means chemotherapy, radiation therapy. So the cornerstone of cancer therapy initially is usually involving surgery, radiation, and chemo, with the idea that that is going to reduce the tumor volume and make it more manageable. And therefore, whenever you're dealing these kinds of therapies, whether it's radiation and chemotherapy, it's always known that younger you are, the better the outcome is. You can recover more. Your repair pathways are better. And so you can then give treatment. So the amount of chemotherapy that a younger person can take is very different than what a 70-year-old can take. Because just think about the damage that's always occurring, the inflammation already. So that means the amount of conditioning is different, and the outcome, therefore, the immune system is better in a younger individual. So there's a lot of pluses for the younger individual with regard to many of the cancer treatments versus an older person. As an immunologist, the older we get, unfortunately, our immune system is limited and it starts crapping out. And in fact, that's one of the theories, is one of the reasons why we get cancer as we age is because our immune surveillance is starting to fall apart. All right. And that makes it more of a challenge with immunotherapy. Within a younger individual, it's much more robust.
Got it. Thank you very much for that. One more question. Elaine says, your thoughts on cancer as a metabolic dysfunction. And I have been reading about this as well, that there are certain school of thought that say cancer is really nothing but a metabolic dysfunction. What's your comment?
I'm not sure what that means, in as much as cell processes are cells need nutrients then to proliferate, to grow, to spread. Normal cells in the body have control mechanisms that say stop. Cancers have removed those checks and balances and keep going. And that's why a big problem with cancer patients is what we call cachexia, which is a wasting disease because the tumor is literally taking all the nutrients. It is a metabolic problem, but it's still at its heart, it's a genetic alteration. These are mutations. So you have to think of cancer as something that has gone on automatic, like a robot out of control. But also, I think what most people don't realize, they think all the cancer cells are the same, and they're not. One of the hallmarks of cancer is what we call genetic instability. Normally in our body, then when our cells get DNA damage, as if we get sunburn, for example, your skin, the sunburn, your cells are dying because there's DNA damage. That's why your skin actually starts peeling because your cells are actually exposed to too much radiation. The UV causes DNA damage, and the cells undergo what we call apoptosis. They die. Cancer cells mutate where they don't go through that programmed death anymore. By that same criteria, the cancer, because of these no more control, are randomly mutating all the time. And so a tumor is not what we would call clonal in the sense of it's all the same. It's all constantly changing on its own. And that by that criteria makes it very difficult to treat. And it's not just the metabolism does play a role, but it's not the driver per se. All right. It's still going to be the tumor's going to take whatever it can. The other thing that when you talk about metabolism, solid tumors in particular, because of the way it's so disorganized, they become what we call hypoxic. That means they're oxygen starved. And actually, if you ever look in the histology of a lot of tumors, there's a lot of dead tumor cells in there. And it's just growing from the outside. And so it's not just the metabolism plays a role. It's definitely been targeted. But unfortunately, that's just when you look at what it takes to make a cancer cell, it's the genetic instability. That's what makes you relapse from chemo. You'll respond, and then all of a sudden it evades. So when we talk about viral immunology, the virus is pretty simple. Whether it's COVID-2 or HIV, it doesn't have a lot of genes. That cancer cell has all the genes you have at its disposal that it can mutate. And they found when they've done genetic testing, the cancers are extremely heterogeneous, and that makes it very tricky to treat.
Very interesting. I love this analogy that the viruses, which can be so damaging and have so few genes, and cancer has the whole arsenal of genes in it. So, tell us a little about the invasion and metastasis and what goes on in a cancer when it is doing that.
So the hallmark of being something, when you hear you have a tumor, you have a mass. So what they're going to do, cancer is primarily defined histologically. Well, they'll do a biopsy. And then what they're going to look for is it contained? Is it encapsulated? All right. And the hallmark of cancer is it actually, the cancer is constantly evolving so it can spread. It can spread because that means it has access to more nutrients. And it can then keep going and going and going. Um, the invasion part means what happens is the cancer now changes in as much as it makes enzymes that allows it to break through what we call the basement membrane, and it allows through to then go into other adjacent tissue areas. The metastasis part is probably the most fascinating component because most cells cannot survive in the blood. If you take your normal liver cells, your normal any cells, and you inject it in the blood, they're going to die. The blood itself, the hemodynamics is very inhospitable. All you have to see, you ever see the movie Inner Space, or when they shrink and they go in the bloodstream, it's very difficult for cells to even survive. The cancer actually will change, and so it can survive in the blood, and then it seeds into different areas, usually where there's high blood flow. Most metastasis will go in the lung, the liver, the brain. This is where you have high blood flow, and that's where the cancer will now take up residence. What a lot of people don't realize is by that time, it's sometimes very difficult to look at a brain metastasis and figure out what the primary tumor was, because it's changed so much from the initial tumor type. So it's the kind of thing where, and therefore how you treat it, because how you treat every cancer is different. Obviously, some cancers like breast cancer, you're looking at hormonal targeting, or prostate cancer. But when you're dealing with the different areas in the where it metastasizes, that in itself creates barriers. It's hard in the brain or in the bone to with treatments. It's also obviously when you're dealing with the metastasis, you're dealing with vital organs. It's also very difficult to treat. And then that's, I think what people have a hard time realizing is when you look at a scan or an x-ray or whatever, and you're seeing a mass, that's billions and billions of cells. And there's what we call micrometastasis, which means it's what we don't see by the image. That's where the cancer is. Unfortunately, when you're doing a treatment, you're looking to see that the tumor nodule shrinks, and that's great. But unfortunately, we don't know where else the cancer is, and it can even reside in the blood. Another fascinating concept in cancer therapy is the idea of cure versus control. So, obviously, you want to cure, right? You want to get rid of it, you want to eradicate the cancer. But then there's the concept that maybe we can control it. And the classic case is there was a young man that had metastatic melanoma in his 20s. Metastatic means it had already spread, and metastatic melanoma usually has a very poor prognosis. He was treated and he was technically cured. 10 years later, unfortunately, he dies in a motorcycle accident, and they donated his organs for transplant recipients. And when you get a transplant from a different donor, you get massive immunosuppression. So all the recipients did. And many of the recipients ended up getting his melanoma. What that meant was he was never cured. The melanoma was always there, but it was controlled. And that was probably the biggest evidence among others. And now for organ transplantation, if you have cancer, and this happened with other kinds of cases too, you're no longer capable of being a donor for an organ transplant, because it means that the immune system may be keeping the cancer at bay. And so that's telling us that the immune response can then therefore be used to our advantage. And maybe we're not eradicating the cancer, but we're controlling it. And that's still a win for the most
Very interesting. That is very interesting. That's fascinating. A couple of questions before we go to another topic. One question is from Nipa. She says, what about the GKI index, glucose ketone index? Is that something relevant to the cancers?
Well, I think what you're going to find is that people are looking, we call these biomarkers. So, biomarkers are basically any kind of indicator that there is a problem, or that the cancer's there, or even we use biomarkers to see if we're seeing a response to treatment, because you just don't want to rely on that. The glucose ketone, I mean, these are all metabolic parameters that definitely can play a role in the sense of giving us an idea on what is the scenario. But the problem is that what I think people have a hard time with is with human studies, with clinical studies. For the most part, we rely on the blood. You rely on the blood for both the serum markers, for even looking at the immune cells. And those are things, unfortunately, we realize are usually very poor indicators of what's going on in the tumor itself. And so even with immunotherapy, for the longest time, we were looking at peripheral, you take the patient's blood and say, oh, the immune cells are activated, but we're not seeing a response. Well, you have to look at every organ, and the environment in that organ is very different. And that's what you want to look at in with the cancer. So I think it may give you an idea with regard to, say, a general metabolic state, but it's still probably going to be very difficult to pin it down as, oh, this is definitely going to be indicative, or it's going to be something that we can use per se. I've been doing a lot of work looking at obesity and immunotherapy. And the thing is, it's unfortunately a very complicated topic. In fact, we could do a whole thing on what we call the obesity paradox. The obesity paradox, believe it or not, is in obesity, cancer is it's bad. It's the cancer grows faster, and your immune system suppressed, and you have worse outcomes, and that's been very well documented. But we had a paper in Nature Medicine 2 years ago, 3 years ago, showing that with certain types of immunotherapy, it was the high BMI overweight patients that actually responded better and had better outcomes, because that same kind of metabolic situation that you see that the cancer can use, your immune system can use. It's just a matter of who wins and then what kind of cancer it is. And a lot of these metabolic parameters really depend on the tumor and how fast the tumor is growing and how much it needs. So you can have acute leukemia or chronic leukemia or indolent tumors, and that means they're very slow growing, and these metabolic parameters are not going to be as useful. So those are all things to keep in mind.
Thank you very much. One more question. Uh, Jim says, does cancer cause inflammation or does inflammation cause cancer?
The answer is yes. So you're exactly right.
I think your mic may have been muted.
Mine? Can you hear me?
Or it may be just my speaker. So please continue.
Yeah. So the
And I'm
answer,
going to just ask the team
okay.
if they can hear you.
So the answer is yes. Actually, inflammation has been shown to play a role in cancer induction and promotion. So it's been thought cancer is actually considered like a wound that never heals. It's a chronic inflammatory state. When you think about when you get a wound, when you get a cut, you get inflammation. And then you get all these inflammatory cells, and it causes blood vessels, it causes repair, and then it heals. All right, it repairs and it contracts. Cancer takes advantage of that and then keeps going. All right. And so cancer wants inflammation. The problem is inflammation has a dual-edged sword. Inflammation is also a great way to tell the immune system that you got to do something. And so we walk a fine line with inflammation. And in fact, inflammation probably plays more of a negative role in cancer progression, in the sense of, and unfortunately, both obesity and aging causes what we call a meta-inflammatory state, a hyperinflammatory state, and that may actually also fuel cancer progression. The cancer itself, some cancers will actually also further fuel that and make what we call cytokines like interleukin 6 and other TNF that also causes blood vessels to come in and allows the cancer cells to escape and become metastasis. So inflammation, and that's why, believe it or not, people have looked at even NSAIDs like aspirin in breast cancer and things like that. At the same point, we use, as an immunologist, sometimes we'll use local inflammation. That's how we think radiation can work sometimes, is it causes inflammation into the tumor, and that's telling the immune system, oh, something's wrong here, let's attack it. And so the inflammation has a dual role. And if anything, that's one thing I'd like to get by with people so they understand. You know, was it Shakespeare says there's nothing either good or bad, but thinking makes it so. Inflammation can be good and bad. The immune system can be good, but it also can help promote cancer progression too. It's just a matter, and that cancer, some cancers are very good at pirating your normal immune cells and helping it make it spread and grow.
Thank you very much. And I could only figure out that you have stopped responding by looking at you. Somehow my speaker is not working. So I'm going to request you to talk about the next topic while I'll fix my machine. So the next topic is the factors that are affecting incidence and progression and outcomes of cancers. So I cannot hear you at this time. I'm going to recycle my machine, but you can please take it from here, and I'll be back soon.
Again, a lot of it will depend on the cancer types, right? And so, and a lot of it will depend on the stage of the cancer. So when you have cancer goes through different stages, right? So it starts where it's basically a cell that's sort of out of control, proliferating, but it's not going anywhere. It hasn't genetically changed enough to actually spread, and it will keep growing. And that's why, even like, for example, when you're going through colonoscopies, and they see polyps. They're seeing what we call these precancerous lesions. You're seeing basically a situation where there's some maybe inflammation, damage, and cells that are basically not behaving what we call normally, but it's not what we call a malignancy yet. And so what's going on is anything that can fuel continuous proliferation um, is basically going to help the cancer cell. So that's where if you have like an obesity or high fat diets, all these things will help fuel the cancer cell. There are some things that, and then further exposure to carcinogens. Well, what carcinogen is, all a carcinogen is something that can causes a mutation, DNA damage. And so, and remember, one of the hallmarks of being a cancer cell is it's what we call genetically unstable. That means even though it can get genetic damage, it won't die. And sometimes that genetic damage will be affecting other cancer pathways that help its progression. It may cause the cancer cell to rely on other growth factors, or it may cause it to make blood vessels come in, or it may cause the cancer to be able to spread more. So when you're dealing with the cancer, as it progresses throughout its stages, right? So you hear about staging and grading. Staging is where is the cancer? Is the stage one is the cancer's in its primary tissue? Stage two, I'm being very general, is it starting to spread into regional lymph nodes? That means our body's got lymph nodes all over the place. So when the cancer spreads, it doesn't just spread in the blood, it will also use the lymphatics. Stage three, it may be what we call distal lymph nodes. And stage four, it's metastasized to distal organs. All these things will occur over time, and the environment that the cancer's in will help fuel that. So if it has a very nutrient-rich environment, or if it has, you're getting continuous exposure to, say, other kinds of carcinogens, um, that's why they say like sunlight. Sunburn is the ultimate carcinogen because it causes the damage. It also causes the cells to try to repair, so it's bringing more cells. It's causing more proliferation, and then there's going to be greater chances. It's like going to Las Vegas, where you now have chances are that the right or the wrong oncogenes are being affected, or anti-oncogenes. So all those things will affect cancer progression. And then it's just going to be a matter of when you look at the age of the individual. All right. Because again, remember I said obesity and aging causes what we call a meta-inflammatory state. We have increased inflammation continuously as you age. There's more damage, more senescence. All of that creates more of an environment that can also give an advantage to the cancer cell, coupled with then your immune system. Your immune system will try to keep the cancer at bay, but as you age, your immune system gets more and more diminished. And that's to anything, even to vaccines. So all those things can affect with regard to cancer progression, and therefore also how it can be controlled. I hope that explains some of that.
Excellent. So I still have a problem with my audio. So I cannot hear you, but I
Okay.
can, I think, talk with you and I can hear you on my other devices as well. So let's continue with our next part of the discussion. And that was the how is the diagnosis done and what are the treatment differences, uh, past treatments versus the treatments of the day? How is that clinical aspect of the cancers?
So it's changed a lot. Some of it's changed a lot. Some of it maybe has not changed a lot. So, I always, tell my students, actually, my graduate students, a great resource is the American Cancer Society website. Believe it or not, it's meant for even lay people to understand the basic processes and then what cancer is. To me, it's always, I find it very disappointing that cancer, even at a high school level, is not really taught, and definitely not, and not even at a college level. You could be a biology major and you only have a very small. Yet when you realize the cancer incidence in this country, it'll be 1 in 2. That means it's going to happen. Now, granted, a lot of cancer is what we call skin cancer, basal cell and squamous cell carcinomas, which for the most part, as we age, we're going to get, and they don't metastasize, and it's basically surgical excision. But still, it's disappointing to me that most people do not have really even the basics of what cancer is, and then therefore, how do we even look for it? Unfortunately, cancer, unless you are genetically predisposed, that's why family histories are extremely important. If your mother had breast cancer and your sister had breast cancer or your grandmother had breast cancer, well, there's definitely something going on there. There may be a genetic predisposition. So family history will tell you a lot as far as risk factors. But unfortunately, unless you have that, you're usually basing it on several criteria. One, you have a pain that is not going away, a lump, night sweats because cancer doesn't sleep. You're dealing with something or blood in the stool. You're dealing with a stage where, unfortunately, unless you're doing some cancers, we look for routine screening, like with mammograms or whatever. But for the other cancers, it's usually symptomatic. And by the time it's symptomatic, unfortunately, it's usually big enough because it's pressing on nerve endings and it may have already spread. So a lot of cancers may have already had micrometastasis by the time of diagnosis, but you're going in because of something that does not feel right. And then you're going to be going, usually it's in imaging. You'll do some scans. And then if they see a mass, then they'll do a biopsy. And that's been the gold standard. It still is the gold standard for the most part on picking up cancer because it's still, for the most part, some of these cancers are very rare. So you're looking for a history. You're looking also for lifestyle. What is your, are you certain risk, overweight or exposure to carcinogens? My father's a New York City fireman, so he's exposed to a lot. So obviously you're thinking certain kinds of cancer risks. Those are things that you're going to be looking for. Once you get the diagnosis, then you're going to be looking for more, then it gets more specific. Then a lot of places will say, okay, we're seeing histologically a certain cancer type, but now you're seeing more and more places doing a genetic assessment. They're doing a molecular assessment. And that will tell you a lot about what type of cancer subtype it is. And that can help dictate the kind of treatment you're going to get. Because if it's a highly proliferating cell, then you're still dealing with a cornerstone of treatment as far as if it's a stage 1, it's localized, you're looking at removal, surgery, maybe radiation to actually get any areas that the surgeon may miss. And then if there's maybe even a chance that it may be spreading, you may be dealing with some chemotherapy or hormone, if it's a hormone block, if you're getting a hormone responsive tumor. If it's more advanced, then you're dealing with obviously more aggressive treatments. So everything is going to be based on the staging and how aggressive it is. The other thing that's maybe changed a lot, say in the past, say 25, 30 years, is what we call targeted therapy. Targeted therapy is where we now understand some of the genes that have been altered in cancer, some of the proteins, the enzymes, or whatever, and there are molecules, drugs that can target that. And we can use that in some cancers, and that can be very specific because the hallmark of cancer treatment is always what we want is selectivity, right? And so you don't want a treatment where the toxicities are going to be such that it overrides any benefit that you're going to get from the cancer reduction. And that's where sometimes the age of the individual plays a role. You're not going to give the same chemo to a 80-year-old woman. And that's where the immunotherapy has been so exciting because some of the immunotherapy allows for that kind of selectivity without, because in the hallmark of most cancer therapies in the past, say in the past 40 years, have been the toxicity of the treatments reach a point where you cannot give anymore, or the cancer has evaded now and is resistant to that treatment, right? And so cancer treatments, say 40 years ago, were giving 1 or 2 drugs. Now you're seeing combinations. So I make an analogous to HIV. AZT by itself didn't work in HIV. But when you do it, combine it with protease inhibitors and triple drug therapy or heart, they found that the virus can only mutate so fast and you can keep it at bay. Cancer has, as I mentioned before, the entire genome at its disposal. But what people are doing, what oncologists are doing now, are doing combinations of these therapies, and what they've learned now, more local. They're giving their therapies locally rather than just systemic, and with the idea that with better targeting and with the use of these targeted therapies, you're going to have better control.
Got it. Thank you so much. And thank you very much that while my own system was restarting, you were taking care of the talk. I have a few questions in the meanwhile over here as well. There's a question, Desire says, do biopsies spread cancer?
That's a good question, because there has been some debate, not so much with biopsies. It's not thought that the biopsies will spread because you're dealing with a very, very small, and it's not as invasive. But there was sometimes a debate in the community whether surgery, because of removing it and you're getting the exposure in the circulation, will that cause? And it's very debatable on that. But biopsies, as a rule, are not thought to spread the cancer at all. Keeping in mind, as I mentioned before, it's thought that if you can see the tumor, that's not necessarily where only the tumor is. The tumors are multicellular, it's cells everywhere. And so there can be obviously tumor cells spread. That's why a lot of times, even surgical excision, they're still going to be doing a radiation or something else, because they know it's what they see on a scan may only be the tip of the iceberg.
Got it. Thank you very much. So I do not know if you touched on this. I'm going to ask you this, and if you have already, then I'll move on. So the treatment, past and present, and what are the factors that affect that decision? Was that discussed while I was not able to hear, or if not, can you?
Well, I talked a little bit. What's affecting the treatment response will depend a lot on the stage, right? So if you have metastatic cancer, you're going to be much more aggressive in the treatment, because you have to be, for several reasons. One, a metastatic tumor is much more what we call de-differentiated or devolved, and it's going to be therefore more heterogeneous and less and more able to evade a treatment, versus a early stage tumor, which is usually more what we call differentiated and therefore more controllable. As the tumor mutates over time, it becomes less and less and less like the original cell it came from, and therefore also more heterogeneous, and therefore more difficult to treat. So when you think about like a virus that changes, usually a virus will mutate such that it evades one pathway, right? But for the most part, it's the virus is homogeneous. When you're dealing with cancer, you're dealing what they found in some cancers, when they just take the tumor cells from a patient from a primary site versus a metastatic site, they can see tremendous genetic changes have already occurred. That means how that tumor is going to respond is going to be much more difficult. And so that's going to affect the treatment. As I mentioned before, the age of the patient will affect the treatment. And then finally, how aggressive the tumor is. There's what we call a proliferation index, and they use this for breast cancer sometimes. Because when you're giving a chemotherapy, it's going to affect all proliferating cells, including cells in your blood and in your gastrointestinal system. And you want to have what we call a therapeutic index, where the cancer cells are going to be more affected by it rather than your normal cells. So those are things that are going to affect it. And then the other thing is people are using more, like I said, targeted therapies, which are going to be small molecules that will target that particular cancer type. So they're going to type the cancer, just like in breast cancer. You'll see if you're HER2 positive, so you can get Herceptin, or you're going to be, if it's estrogen receptor positive, then you're going to get hormone blockade. All those things, you have to individualize the cancer treatment to the cancer and then the individual himself, herself, because all those to the outcome.
Got it. Thank you so much. So, KoolBeens, if you have some questions, I'll get to them in a second. I want to ask one more topic that I want to make sure that we touch on before we answer some more questions. So, the one more question to you, Dr. Murphy. How are you studying cancers in your labs? How are these cancers studied? What is the difference from studying in lab versus cancers in human beings or animal models? Uh, Tell me a little about that.
Yeah, that's a whole topic in itself because unfortunately, the bedrock for cancer research has been generating what we call tumor lines. Maybe you've heard about the Henrietta Lacks story, the HeLa cells. It's basically, if you take, most people don't realize we can take a tumor out from an individual, a cancer from an individual, and that cancer, even if we put it in what we call tissue culture under sterile conditions with a lot of different factors, most of it dies. So cancer cells will, and it's been hard to study that way. But what's been the bedrock since the 1970s has been tumor cell lines. That means they've taken cancers from a patient and they've been able to actually generate a tumor line. That means a cell that can survive outside the body. The problem with that is over the years, that becomes less and less like the real cancer. So that's been a big problem in the whole cancer field, in the sense of how do we model that? And then also, most studies with human tumors and human cells are what we call in vitro. That means in a test tube. Well, anything can kill a cancer in a test tube. You can put water on and it will kill. I mean, and that really doesn't tell you what's going to work with the complexity of in vivo. So usually you have to rely on what we call animal models, and the mouse has been the bedrock for cancer immunology and cancer therapy because of they have a short lifespan and we can make them what we call immunocompromised. That means we take away their immune system and we could put human tumors in them. The problem with mice is mice aren't people, and also mice don't get human cancers. And so that's been so that there have been a whole area of cancer studies where they've tried to genetically modify mice so they get the human type cancers, and that's been giving some insights. But the species differences are huge. But what's really changed the field is what we call PDX, or patient derived xenograft. And so what we can do is we can take the cancer from a patient, put it in the mouse, and that cancer, including the normal cells in the human cells in there, will grow, and we can then see how different treatments will work on that. And that's probably considered a better. It's expensive, but a better model to rather than these tumor lines, which may not even represent. Yes, it will keep growing, but whether that's going to show the same kind of therapeutic effects is a whole nother issue. So it's changed a lot, and I think we still have a long way to go.
Got it. Thank you very much. So these are the topics that I wanted to discuss. Now, a few questions. I'm going to start with my question that I was discussing with you before the talk, and that was sort of when will we conquer the cancers? And I think your answer was in the line of as we are changing and we are knowing more, the cancers are changing as well.
Yeah,
So,
I think that
how is this?
when you think about it, same thing with viruses, right? You can cure smallpox, you can cure polio, but then all of a sudden you start getting nature will always find a way to stress the system. It has to. And so cancer has been changing, right? Because as I mentioned before, and also think about it from the standpoint, our immune system has never evolved to fight cancer. Our immune system was evolved to fight infectious disease because throughout the thousands of years of our, or even millennia, because of even in mammals, it's been bacteria and viruses that actually will, kill an animal, and that's what your immune system has evolved to fight. So our immune system, what we're using with our immune system is some of the same patterns, same pathways that we use to fight viruses. The T cells and the NK cells actually also work against cancer. And so we're actually pirating ourselves with immunotherapy, things that we normally use to fight viruses. But our immune system really has not been able to evolve where cancer was at what we call a selective pressure, because again, it's a disease of the elderly over the age of 55. And that's a relatively new, as a species, occurrence. And so I think what you're going to find is as our society changes, the cancer will change. Just like as we take care of some viruses, new viruses come. we're seeing now as a society changes, new cancers are appearing that we're not quite sure why. And as we're living longer, we're seeing cancers coming up. So the other thing is, in the past, we're getting the big issue is, well, why aren't we making more progress in cancer? Well, we're also being better at picking up cancer. So in the past, maybe you didn't even know there was cancer there, but you died of old age or you died of something else first. Now we're taking care of some of those other issues, and the cancers are coming up, and we're picking it up. So I think that we may find certain cancers we're going to make more progress on, and then certain cancers we're going to probably find we're going to understand what causes them more. So prevention is still the best thing. Everybody wants, so with chronic myelogenous leukemia, CML, there was a pill called Gleevec, which was a targeting agent, which is wonderful. It targeted the cancer, only the cancer, and it was great, and there was no real side effects. And I'll never forget when the director of the National Cancer Institute at a big meeting said, this is going to hurt our cancer field more than help. And people were shocked. How could that be the case? And he goes, because the public's going to expect the same kind of reaction, same kind of pill for every cancer. And we're now realizing breast cancer, colon cancer, that's not a leukemia. And so we need to realize that will work in one is not going to necessarily work in the other. And then some cancers are extremely difficult to treat, right? When you talk about pancreatic cancer, glioblastoma, you're dealing with, it's just a fundamentally different type of cancer that may be more difficult.
Makes sense. Thank you very much. So I have a question here by Michelle. She's saying that, do you know if there is any good information about immunotherapy for myxoid sarcomas?
Yeah, that's funny because we work on sarcomas. Sarcomas, unfortunately, is you know immunotherapy is finally coming to its own in certain cancer types. So lung cancer, nobody really would have thought, and now it's a frontline therapy. And we'll have a discussion on what is immunotherapy, because there's many different types of immunotherapy. And everything, when you think about it, everything's immunotherapy. Even what you eat is immunotherapy, because you're using your immune system to some point. Your immune system has to be playing a role. It's just about how much of a role do we want to play. Unfortunately, with sarcomas, there's not a lot of there's a lot of clinical trials going on, and it depends on the type of sarcoma you're looking at. But for the most part, immunotherapy has been, when I was doing immunotherapy, this is again 30 years ago, it was mainly melanoma, lymphoma, and renal cell. Now we're seeing it being more and more applied to other kinds of cancer types. That being said, it's still in its infancy on how we're going to apply it to some of these other, because sarcoma is a more relatively rarer tumor, and it hasn't really been bearing out as much as far as the immune responses.
Understood. So two more questions. I know that it's almost an hour. One question is here, Midazolam says, could you please ask what type of cancers ivermectin cures?
So ivermectin obviously has many different effects, and so we've heard it a lot more used than with obviously the Patentine. So there's really, when you say cancer cures, there's really not many things that cancer cures. As I mentioned before, oncologists are using a combined approach, just like in a military operation. One thing's not going to do it. You need a lot of different weapons in your arsenal. And it's and what we're finding, it's also the timing on how we use that. So ivermectin, unfortunately, is one of those things where there's really not a lot of robust data. And you're going to find in literature a lot of data. You'll see there's the plethora of journals that will publish almost anything. And I'm very skeptical on that, because nobody publishes something doesn't work. Everything publishes that, oh, we see this effect. And most of these studies are what we call in vitro. That means you take a tumor line and you put it on, and like I said, you put enough water on, you'll kill too. And so that's the tricky part, is trying to decipher what actually works from in vitro versus in vivo, which is a lot harder, and then how it represents human cancers, which are much more difficult.
Understood. Thank you very much. Paul says, wouldn't cancer be a large concern for larger animals such as whales and elephants, which I understand do not get cancers? Is there something good here?
No, not
No, not
necessarily,
necessarily,
because it's also
because
a matter of how do we study that, right? And it's going to be incidence. And you're dealing with animals in the environment. So, for example, I work on laboratory mice that are inbred. And a laboratory inbred mouse can live up to 2.5 years. A wild mouse lives 6 months. And so what that's telling you is in the wild, cancers, and the same thing of even in human evolution, when we were actually trying to just survive, you didn't really hear about cancer because nobody lived past 50. And so for the most part, you're not, and then also the incidence, even the cancer, when you look at the cancer incidence, it's still relatively small in this country compare, or even in other countries compared to, so when you're dealing with a wild animal population, it's going to be very difficult to how you
very
monitor
difficult to monitor.
what's going on in a large animal, much less because even in human beings, we may not see it, and the animal may be dying normally from other things, but may have cancer, and you just don't know. And so it's not an absolute that they don't. It's just going to be a matter of, and it's not the size. It's also going to be, again, in the environment, animals are not necessarily ingesting all these kinds of carcinogens, dealing with obesity and living really long because everything else is taken care of. And so, for the most part, because we've taken care of infectious disease, it's not like the other animals have taken care of infectious disease and they are dying from that. And so, you're not, cancer is almost a disease where you have the ability to live longer and therefore succumb to it versus in other kinds of situations where that's really the least of your worries.
Got it. Thank you. And one last question, and this question kind of is interesting because we started from CAR Ts, and this is the question for CAR T. So Svetlana says, what kind of CAR T therapies are in clinical trials right now, or do we have those in US now? It used to be a big deal asking for somebody with lymphoma.
Yeah, CAR Ts are here to stay. They're FDA approved. So that means they are now an accepted regimen for certain kinds of lymphoma and leukemia, mainly B cell. That means it's not even a trial. That means they're available. And usually you see them at the what we call comprehensive or academic medical centers because we have to make our CAR Ts in what we call certain clean facilities, but they're available now. I would recommend you just go on just a regional cancer center website because the comprehensive cancer centers are throughout the country, right? And they are therefore capable of giving information regionally on what's available as frontline therapy. There's hundreds of clinical trial cars. They're all over the place, and so they're available. And so all I would just say is just look them up, and you'll probably find some.
Awesome. Thank you so much. So, with this, thank you very much for your time, Dr. Murphy, and your insights. You are doing this work for 35 years and you are running this lab and you're teaching. Thank you very much for your time to teach us and share your insights with us as well.
My pleasure, and I'll see you soon.
Absolutely. Bye for now.
Bye.
So, KoolBeens, with this, thank you very much. I know that there are still some questions that are left. We would do a series on cancers and we're going to do a series on pain management. So, hopefully, in the next talks, we would take care of some more of your questions. With this, thank you very much, and I'll see you tomorrow. Bye for now.